I'm Istvan Urban, and I'm here in the Regeneration TV studio with my very good friend, Professor Khoury, who accepted our invitation and accepted to make an interview with him. Thank you very much and welcome.
Thank you. Thank you for the invitation.
You just had a fantastic lecture, really loved it. And there's some issues that we can discuss, very good questions. So tell me a little bit about the concept of why still today you think, or we think, the autogenous bone is important.
You know, autogenous bone is important because we need the information for the regeneration. Autogenous bone, when you are grafting autogenous bone, we are grafting a free graft. And by grafting a free graft, part of the cells will die. And through the dying process, we will have activation of the regeneration, because through the dying process, we have expression of BMPs, of bone morphogenic protein, who are able to influence the pluripotential cells to become osteoblast. So this dying process, which many people were, let us say, saying that it is bad because the bone will resorb, but this dying process is activating the regeneration potential, and this is, I think, a great thing for reparation. It's a physiological reaction of the body to repair everything dying in the body.
So basically, in the autogenous bone, we're transplanting vital cells and growth factors,
right,
which we need for these very advanced defects. So I really agree with that. Now, in terms of other issues, like when they graft autogenous blocks in one piece, in your and also in my technique, we mostly like to use the particulated bone. Where the implant goes is also for you a particulated bone. So what is the advantage between a particle or a block? Because clinicians may think, okay, which one shall I choose?
You know, a thick block had a problem for the revascularization. That the blood vessels go inside of a thick block is, of course, difficult and depends on the regeneration potential of the recipient side. So we saw that in the recipient side, sometimes we have beautiful revascularization of thick blocks, but sometimes we saw very poor revascularization. And if this bone has a poor revascularization, it will be bad for the future, because we are working in the oral cavity with a contaminated area, and poor revascularization is not so good for the long-term stability, because it can't resist against the oral flora. From the second part, in autogenous bone, we have BMPs, but this BMP is inside of the bone. So how to deliver it outside of the bone? In thick blocks, it will stay inside. If it will stay inside, it's not going to react. By cutting the blocks in two and thinning it, we are getting bone chips, and we are getting thin blocks, which are much easier to be revasculated. We are getting bone chips with a better surface to get better regeneration through osteoconduction, and we are exposing the BMP so they can react with the stem cells to get more osteoblasts in the region. So that's why we have a lot of advantage by using a sandwich technique, a hamburger, okay, instead to use a thick
so
part of bone.
Basically, once we particulate a bone, we can also, do you ever use a bone mill?
Yes.
So let's say we use a scraper or bone mill, we particulate bone. We are growing the surface, we are gaining surface, we're gaining the exposure of the growth factors and the cells, and we're growing the whole volume.
That's it.
So once we have a piece of block that we particulate, we're gaining a lot of volume, and people may be underestimating that, because you don't need to take so much bone when you're growing bone with the particulation. Now, in some countries, especially in Germany, but also in some countries, they're advocating 3D printed blocks, for example, allogenic blocks. And it is very popular, but I'm yet to see any really long-term outcomes. Do you have any experience with that?
Yes. We see a lot of complication with that, because the problem is the revascularization. You know, this allograft can integrate very beautiful. I don't say no. If they are not exposed at the beginning, they can integrate. But the problem is the revascularization. They have only revascularization only on the border of the local bone. So even if they are good integrated, they still have low vascularization. And the day where you are going to expose them to the oral cavity and to restore the implant, this kind of graft will have contact to the oral cavity. And then the problem can start, because bad vasculated bone graft has poor chance against the oral flora. The day where you can reach that this graft can be, you can do something to get a better revascularization, I think that it can function quite well, but we are not so far.
Have you ever tried it?
I didn't try. I saw only cases coming to us with complications.
And what do you see? Do you also see that sometimes they place this? Because what I've seen, that was the implants were in, and looks like it's functioning, and 3 years later you see the block that is dead.
That's it.
Exposed.
That's it.
So that's what you're talking about.
That's it, and you see no blood vessels inside. Mm-hmm. It is totally dead.
And I see that also, you know, with different types of like products in terms of block products. Also, let's say you have this type of block that they did 3D printed, allogenic, xenogenic, or you know, not an autogenous from the patient. Let's take that. Let's take an autogenous block, one piece, and let's take a particulated bone graft. And let's say you get an exposure with a 3D printed block, a full bone block, or a partially particulated bone graft. Which one do you think is the most favorable in terms of the outcome?
Of course, the particulated has more chance for repair, because a thick bone block needs very long time to be revasculated. We saw sometimes 5 years, 6 years, and part of this bone is still dead. If it is exposed and you have the infection, how to fight against this infection? No chance.
No chance.
If you have particulate bone, you have earlier revascularization, you have blood vessels, and if you have exposure, you will lose something. Of course, every time you have exposure, you will lose something, but you are not going to lose everything. And this is, I think, a very important part. And at least, Istvan, what you are using and what I am using, I think we are using a similar technique. What we are doing is also a kind of GBR.
Yeah,
but we are using the bone as a membrane.
Yeah, I think it is.
And you are using the membrane as a membrane.
I think biologically what we're doing is very similar.
So we are using similar technique with particulate material. The only difference, we are using the bone as a membrane.
Right. And we also have the experience, and I think this is very important, in case of potentially a graft exposure, or potentially what we call a low-grade infection, when you have one area, I don't know if you have seen that, have you seen that maybe with a fistula, and when we went back and we lose or scrape out part of the bone graft, but the other part is going to survive.
That's it.
And we never see that with a block.
That's it.
So I think
with a thick block, you're right. That's why this layers grafting procedures is giving your graft more chance to survive in case of complication.
And also when you, I don't know what your experience is, what would be, if you would have an exposure with a block that was printed or something like that, I think if you have an exposure, there is bacteria. But then how do you scrape that out? The bacteria is locked in a cage. So it's very likely you're going to lose all those grafts that are not particulated, and if you get an exposure. So yes, we can agree then
yes,
then we have
with thick blocks, if it is exposed, you will lose everything.
So we have more chance to get better vascularization of our bone grafts.
That's it.
Better tissue integration and better BMP and cell activity, and a better chance to treat a complication.
Yes. When we are using bone chips.
So tell me now, historically, because you have changed, come in.
Okay. Yep.
Dr. Khan has arrived. Welcome.
Thank you. Thank
Joe.
you. Yep.
So what would be your I mean, how did you came up with this idea? Were you unsatisfied with your blocks, and that's how you came up with this idea? Or
Yes.
also the adaptation is much easier because you don't have to adapt, right? The plate, the block, you have to be kind of like Michelangelo to adapt it to a rough surface or an irregular surface. Your bone plate doesn't have to be. So I was thinking about, how did you get the idea? You didn't want to adapt, or you were fed up with the vascularization, or both?
Okay. You know, we started very early with autogenous in the 80s already. And of course, at that time, we were grafting thick blocks. Autogenous for us, autogenous were always autogenous. And the interesting thing that we were looking to our cases, and after a certain time, we saw already during implant placement that this bone is not bleeding. We were drilling inside of this bone, and there were no bleeding, and no bleeding is not a good feeling. You know, you need blood. So, and we saw after we restored our implant that this bone was not stable. We were losing bone. So we start to make histology during implant placement, take some bone cores, look under microscope, and we were surprised to find, even after 4 months or 5 months, to find a big part of this bone, dead bone. So you see that bone, so you try to start to think, what can I do to improve the bone quality? So you look to the literature, you see how other people are working, you see the GBR technique. At that time, you know, Simeon started to make GBR, Denny Boozer started to make GBR.
But it was difficult.
You know, of course. And we started also to make some GBR, but we had the problem with the complication, with the exposure. And so, but the idea to have that particulate is going to heal better than piece of bone, we learned from these, from the GBR. We saw the histology that's going to heal. So we start to think, okay, we don't want to use membrane, but we have something to have similar. So we start to cut the block at the thin membrane as a biological membrane.
What year was that? Do you remember?
It was at the beginning of the 90s. The first publication, I think we published on 94.
Nice.
92, I'm sorry. So, and we follow it all the time. So we're doing about 30 years now.
That's great.
And by using the bone as a biological membrane. So at least we are following the GBR principle.
Exactly.
But by using the bone as a biological membrane.
But so interesting. At any point in your career, you ever consider with your bone plate, rather than putting marrows in there, have you even tried putting biomaterials in there? Has that even been tried?
Yeah, we tried.
And what's the results there?
We didn't find the similar result as by using pure autogenous.
Similar results, meaning better? What are you looking for?
Yes, by using biomaterial, we found, because we were not using any membrane. That's the difference. So by using, biomaterials are dead materials. If you don't protect them from blood vessels coming from the soft tissue, you will have growing of soft tissue in between.
Okay.
That's why all the people, and Istvan always, when he is using biomaterial, you have to protect them from the blood vessels coming from the soft tissue. So we are not using membrane. That's why if we put biomaterial with it, we saw a lot of invagination of soft tissue in between this biomaterial.
And this was a mixture, or it was just purely biomaterial?
We tried everything. So we found that the best result clinically, you have always a smooth surface, clear surface by using pure autogenous, because we are not using membrane. In case we have some experience by using membranes, and I think I'm 100% with your concept that the Gore-Tex membrane is the only one who's able to make guided bone regeneration for vertical bone augmentation. If you know how to deal with this, and that's what you know, very good to deal with this.
Then, if that is the situation, can you please comment a little bit? I'm sure you've seen Istvan show, with a newer membrane with like some pores, some holes in it, literally.
Macropores. We now
So-
make holes on the membranes.
Literally
Okay, I don't know.
holes there.
I know only the old GGBR, and from my experience, if the membrane is not exposed, is not infected, you have always excellent result under the membrane.
Maybe Istvan, may I ask you, since with the pores on the membrane there, is it a concern of the tissue going invaginating into the graft?
So we have done two things. One, a preclinical study when we had 3 groups. One, the solid membrane. The second one, perforated membrane. Third one, perforated in a collagen membrane. And we looked at how much soft tissue we get, how much bone we get, and how much remainder of graft material we get. And we found there was no difference. In the humans, we're using the hose and basic collagen membrane because we were afraid that some soft tissue may grow in. It might not be so much of an issue, but I agree that you have to have a certain amount, which is a high amount, like I would say more like 60% autogenous bone, to have good connection. And it would be also very nice to see, and what you think about, like let's imagine that we have my technique or your technique, we have the biological membrane or the membrane. Let's say we would do some biomaterial, but on the top surface, if you would do like a sandwich of autogenous only, or a mixture, what do you think if we would do like a little bit of a biomaterial, autogenous, and sandwich on the top, just autogenous?
I think if we have to do something like this, we have to put the biomaterial
Deep.
deep. The biomaterial close to the recipient side
Right.
to have a better revascularization, and the autogenous on the top.
By the way, I always wanted to ask. I've read the 10-year study by Boozer, where they were using a combination of blocks and GBR. And what they have found is that they had a little bit better results with the chin than the ramus. Do you see any difference between different regions where you harvest bone from?
Yes, in the chin area you have more cancellous bone, and the cortical bone is thinner. So of course that the chin quality, because you have more cancellous, is from the regeneration point of view better than the retromolar. But the chin area has a high morbidity. Every time you remove a chin block here, you have to know that you are disturbing the sensibility of the lower fronties. That's why chin block is for us an alternative in case of a dentalist patient.
Exactly.
If the patient has no teeth here, okay, you can remove bone. And from the second point of view, it's much easier to harvest a block from here than to harvest from here. Harvesting block from the chin is difficult because you don't have the step. Here you have the step. And I showed you in the video, we make the perforation, you connect the perforation, and the block is coming out. Here you have to remove it from the body of the...
More difficult.
Yes, it's from the surgical point of view, it's more difficult.
Because of also there's a curvature there, so
Yeah,
it's
that's
hard to get that plate really nice and straight too.
But the quality, of course, it is more cancellous.
But can you comment a little bit about, obviously, there got to be some mobility when we work at the posterior mandible, the ramus area too, right? So you probably don't have much, but how about your students or your disciples? Do they have some complications, some mobility issues?
We have a protocol. If you follow the protocol, it's very safe.
Okay.
It is like every protocol, similar with this technique. He has a clear protocol, he informs his student protocol, and who are following the protocol will be happy. Of course, you need the surgical.
There is also one of your students developed like a stent, right? For the beginners.
Yes.
That you can digitally plan a stent.
Right.
Yes. At least there is a protocol what you have to follow. And these techniques are sensible, from the surgical point of view are sensible. I think the people who are going to assist to a lecture will not be able to follow the protocol if they are not doing a course. The people must learn, and they must have surgical experience for vertical bone augmentation. Vertical bone augmentation is not a technique for everybody. You agree with me?
So
You need a lot of education for that.
in your opinion, to understand your technique, as a student to be able to execute? How much time? What would you recommend them to do to be able to be professional enough so that they can be on their own and do this technique successfully?
You know, it depends on the experience of the guy, of the surgeon. If he's just finishing the university and he has problem with the removal of wisdom tooth, so it's better not to touch something like this.
Absolutely.
You need surgical experience.
Okay.
Okay? So if you are able to remove an impacted wisdom tooth, deep impacted in 20 minutes, I think you will be a good candidate.
And then with that type of candidate, will taking just like maybe a 1 week course from you, will that be sufficient?
If they have surgical experience,
right.
I think always, because with the 1 week course, you learn the technique, but you don't learn the surgery. You have to be a surgeon, okay? So you have to be comfortable with flap preparation, which is very, very important, how to augment. If you are augmenting 10 millimeters vertically, bone grafting is not difficult. Difficult is how to close it, how to prepare your flap. So this, you must be able to do this, then you can make vertical bone augmentation.
Does that go the same for your technique too, the sausage technique?
Yeah. I think, depending, we have different programs. We have one program called the Regenerator. You from a bone terminator, you become a regenerator. And that takes 3 sessions.
Sure.
So then the first session is all about, to get the skills.
Right.
And to learn how to make that flap, learn how to advance that flap. And which we call the super full thickness flap, the flap that is like the best flap in your life. And then, but somebody who's very experienced can come for a 3-day course.
That's it.
And we have closed like Facebook groups where we follow up. And you know what, they're doing great.
Right.
They're doing great.
I guess that goes the same for all techniques, just like even immediate implant placement.
Yeah, I think so.
Even you learn the concept, you still need to practice it to be able to experience it and master it.
Yeah. So one last question, because we have to get back from you.
Okay.
How if I'm a novice clinician, I placed implants into native bone, how much time do I need to learn? How much of a course do I need from you to learn how to do immediate implants?
Immediate or immediate provisionalization?
With the provisional.
Well, pretty much, if someone with some experience, I would say that probably like a, 2-3 day course to get everything, all the basics down. Then after that, I would recommend them to go back to practice some and then come back again. Because, as students, what happens is I found out, even when I attend you guys' lecture, when I learned the bone plate technique, I go back, I try it. When I listen to you again, I see a totally different thing.
Exactly.
Even you talk about the same thing, it starts opening the things into,
right. You
and that
pick other things up.
And that's the unique thing about learning from the master. Because every time you listen to them, it opens doors once you practice. And it's a step-by-step type of thing. That's the beauty of it. Yeah.
Well, thank you so much for your accepting the invitation.
Thank you. Thank you for the invitation. My great pleasure.
Thank you so much.
Yeah, and it's always a pleasure.
Thank you.
You
Always
are
a pleasure
master.
for me also.
Thank you, Istvan.
Thank you very much.